Hey, it's me, Karen, with Aortic Hope. Going to try this a third time. And a matter of fact, the first person, well, no, I'm going to hold my little contest to myself. We're going to wait for Jennifer to join. And hopefully it works. Let's try this again. It's like the Twilight Zone. Bobby's watching. Good. Got it. Let's see everybody else. Come on, Jennifer. It prompted her to update her Facebook settings. Okay. Third time's a charm. All right. Claire. This is Karen Anderson, and I've had 10 injections in my face with Novocaine. That's why it looks like this. Now, I'm not going to repeat everything again. Hey, Andrea. Hey, Maria. Faith. Trying. Yes, Sherry, you found it, except we've had 2 technical issues, so we're not 100% sure it's going to work, but I'm feeling really positive, and I'm going to try to bring Jennifer on now. And let me try. As it's adding, so Jennifer, check the bottom of your phone. I sent you a request. You're connecting. It's working. Yay! We are here. Oh my God. I've had to tell everybody about my 10 injections in my face.
All right, perseverance for the win.
Oh my God, this is so great. Thank you so much. I haven't seen you since the symposium.
I know, it's been almost 6 months. It's crazy.
Flew by so fast. So what I'd like to do tonight, we've been working with John Ritter Research Program and sharing some of their information. And I guess before we get into any details, I want you to introduce yourself, tell everybody a little bit about yourself. And then I really want to explain the importance and what a clinical testing is, and just why would somebody be tested and all of that. We'll get into the who, what, where, whys, and everything. But why don't you take the floor and just introduce yourself and explain what you do and who you work for.
Sure. Well, first of all, really happy to be here, and thanks to everyone for their patience through our technical difficulties. But my name is Jennifer Hare. I'm a certified genetic counselor. I currently work for a clinical genetic testing lab called GeneDx, and I'm in their cardiovascular testing department. So in addition to offering testing for conditions like thoracic aortic aneurysm and dissection and the related connective tissue disorders, we also offer testing for inherited cardiomyopathies or inherited arrhythmia conditions in my division. Now my lab as a whole is much bigger, and it goes beyond cardiology and offers testing for a bunch of different types of disease that might have a hereditary or genetic component. So things like hereditary forms of cancer, just generally rare diseases, neurologic conditions, kind of runs the gamut there. I've been with GeneDx for about 2.5 years. Prior to coming to GeneDx, I had more of a clinical counseling background. So I primarily saw patients who were at risk for conditions during pregnancy, the fetus being at risk for conditions, or inherited cancers. But I did a little bit of cardiovascular and other more general genetic clinical counseling. So now I've sort of have both sides of the spectrum, knowing what it's like seeing and counseling patients on the clinic side and ordering genetic testing in an effort to maybe get an explanation or an answer for why someone presents, as he or she does. And then on the other side, now that I've worked at a clinical lab, I understand when we receive the samples, how we do some of the testing, why we do some of the testing, how we interpret genetic variants that are found and how we classify them, and then how that all is transmitted back to the ordering provider in our report, and how that information is then ultimately conveyed to patients.
So a lot of us never find out we had an aneurysm. We just spontaneously dissect, whether it's A or B. And then a lot of us have the luck of finding out that they have an aneurysm. Who would be the appropriate person? I mean, which patient, I'm sorry, I'm trying to talk, which patient would be the appropriate patient, I think I know the answer to this, to be clinically tested?
Yeah, so as you mentioned, sometimes it's tough too that there's no prior knowledge that you have a dissection, and maybe that's the first indication there's something going on in the family. Other people, may just incidentally find that there's an aneurysm, or there could be a family history. There's no best person to test per se. So things that we look for in terms of who's going to be at greater risk for having an inherited or genetic finding are going to be those with very young ages of aneurysm or dissection detected. Those individuals with a strong family history, so multiple others who've had dissections, or there's a strong family history of sudden death, things like that, or those who have a very sort of rapidly progressing well. And so we look at each individual case so there's some general guidelines, but I think each case is unique in its own right. In general, it's always going to be better to test the person who's affected, so the person who's had the dissection or has the known aneurysm, as opposed to relatives like siblings or children, for example. But we know right now there are some limitations in terms of the pickup rate in genetic testing. So sometimes we can look clinically at a family history and see, yeah, there's people affected down through multiple generations. There's clearly a hereditary component, but that doesn't always guarantee that with testing as it stands now, we're going to find that genetic explanation.
Okay, so I guess if you're just considered a one-off, and you do know why your parents or grandparents passed, and it isn't from anything vascular related, then it's not. Are you saying not to be tested, or who do you talk to? Is this a cardiologist call?
So cardiology, you're going to be looped into cardiology if you have that type of history, right? So that's a good place to start. The other thing to consider too is you might want to meet with a clinical geneticist. And the reason I say that is we know that sometimes aortic aneurysm and dissection can be an isolated finding, and that we're not seeing any other abnormalities of other systems of the body. But sometimes that can be one of many features that encompass a larger underlying genetic syndrome. And some examples there would be like Marfan syndrome or Ehlers-Danlos syndrome. A clinical geneticist is a doctor who's specially trained to do that clinical evaluation, looking for those other physical characteristics, or maybe referring that patient to other specialists like ophthalmology or neurology or dermatology, even to see, do those pieces fit for an underlying genetic syndrome. And so that's where we sort of look at each patient individually with what's going on clinically, what evaluations has that person had, and then what's going on in the family history too. Obviously, somebody who dissects at 25 or 30 is going to be more of a concern for an underlying genetic or hereditary component than somebody who dissects at 75 or 80. So looking at all of those pieces, if you've had an aneurysm and dissection, I wouldn't say that you should, that there's a group that should never have testing. I think we, at least at the genetic testing lab, rely heavily on the clinician's suspicion and what he or she thinks about the value of genetic testing in that individual, and also how motivated that person is to find a potential genetic explanation. And oftentimes finding that answer may not directly impact that person's care, since he or she's already plugged in with cardiology and specialists since there's been an event. But it may have great impact for presumptively unaffected relatives who could then be tested if a disease-causing variant is found, to see, are they at risk, and do they need to have closer follow-up.
So if they talk with the cardiologist and they decide that they don't feel they need to be tested, but the individual feels they should be, or that it would make them feel more comfortable, can patients actually contact GeneDx on their own, or do they need this like a script? How does one even go about having the testing done?
Yeah, so that's a great question. And we shouldn't be confused with some of the other genetic testing labs that are available that are considered direct-to-consumer or DTC genetic labs. And what that means is we need to be the one who orders the testing at our lab, because we are not the ones in most cases who are providing results disclosure and follow-up. We need to know that a physician or genetic counselor or nurse practitioner, somebody qualified, is essentially taking responsibility for reviewing the patient's history to order the appropriate test, and then when the results come in, are taking responsibility for interpreting and explaining those results in the context of the patient's history. Because genetics can be very complicated, and understanding results or what's written in a result report and what that would mean for an individual's management and potentially for family members should really be discussed with somebody who's familiar with that type of testing and information.
How do you do the testing?
So practically speaking, the most common sample type is blood. So we get 3 to 5 mils of blood that's sent off. Another very popular way to get specimen is a buccal swab. So a little cheek swab, the inside of your cheek, that contains cells and DNA that's actually mostly in origin from white blood cells, believe it or not. But that's our second most popular way to do testing. Both are pretty effective. Blood is the gold standard. The buccal cells work well the majority of the time, but they tend to fail a little more often than blood, just in terms of getting the appropriate DNA concentration and quality out of it. There are other types of samples that we can accept.
Okay.
And sometimes that comes into play if, say, we're doing post-mortem testing on an individual who passed away. Maybe we have a tissue sample or something not conventional, or maybe the medical examiner's office had a different sample they already extracted DNA from and want to send that to us. So we're much more open and willing to accept different sample types, especially in those cases where we can't get the desired sample type for testing.
How much does it cost? I know a lot of people are wondering how they go about this. Is it covered by insurance? And if not, how much does it tend to cost?
Yeah, so there's a huge spectrum related to cost. In general, I will say for patients undergoing genetic testing panel, so say we're looking at a panel of genes related to thoracic aortic and dissection, aneurysm and dissection, usually the list price is going to be in the realm of $1,500 to $2,000. And that's sort of just generally in the market across labs. What patients wind up paying can be vastly different. So for example, at GeneDx, if there's financial hardships, we take that into consideration and have a sliding scale based on that. Or if a patient's willing to pay out of pocket up front, there is the reduced cost. Or we're willing to work with a patient and set up monthly payment plans over a year or 2-year period. With insurance, it depends whether insurance covers it or not. I think the momentum lately has been more and more insurance companies are seeing the value and the long-term cost savings in doing genetic testing for their patients. However, they're much more likely to approve genetic testing for somebody who's affected versus an unaffected relative.
Okay.
What I say though is the general testing strategy, when it's possible, is to do a larger panel, which is more expensive, in the affected individual. And then if there's a variant that's found that we think that explains what's going on in that affected individual, targeted testing just for that variant and family members is much less expensive, usually in the realm of about $200 or $300.
Okay.
While, say an unaffected child of somebody who was found to have a variant, maybe that child's insurance company is not willing to cover the cost of the targeted test, but at least we're looking at a much lower list price.
Now,
go
ahead. Sorry.
I was just going to say then sort of that third category is sometimes the institution that's ordering testing will cover the testing. And it may be their policy, or they may have certain funds set aside for families in need where they would just cover the cost of testing. And that could be potentially a negotiated price that's different than the list price.
Now, I've heard it said that if you're going to be tested clinically, you should, if you're thinking about life insurance, you should do it. Or if you're going to have your children tested and they've never been diagnosed with something, you should get them life insurance ahead of time. Can you explain that a little bit?
Yeah, so there was a law that went into effect in 2008 called the Genetic Information Non-Discrimination Act. And so that was an act put in place to save individuals from discrimination from employment as well as health insurance, that basically an individual couldn't lose their job or have higher premiums or lose their health insurance on the basis of their genetic testing status or genetic testing results. But there aren't provisions in there that specifically address life insurance. So, sometimes life insurance may be privy to that sort of information in the health record, or you have to answer questions when you're applying for life insurance. So there has been some discussion in the community that if you're considering genetic testing, especially if you're an unaffected relative, so that you wouldn't already have information in your medical record that would be suggestive of that, to get that life insurance in place before moving forward with the genetic testing and getting your results.
Okay. All right. So talk a little bit about the genetics, the genetic mutations or the affected genetics that you are testing for. What are some of the things that you're looking for when you do this?
Yeah, so the way our testing works is there will be, most of the time people start with panels, as I mentioned, and there are a number of genes on these panels. At our lab, we're pretty cautious about what genes we officially add to panels. We want to make sure there's information in the published literature that are linking those genes, say, to a condition like aortic aneurysm and dissection, that we feel confident that there's a strong association. For the most part, the way that we're looking at those genes is two ways, through sequencing and deletion duplication analysis. So just a review, our genes are made up of tons and tons of letters of genetic code in a certain sequence. And we know what's generally expected to be the normal sequence of those letters. So when we sequence an individual's DNA, we have two copies of every gene in our body, one from mom, one from dad. We have technology that reads through all the letters of those genetic code and looks for changes in the letters, which would be considered a sequence variant, or looks for chunks of that gene that are either deleted or duplicated, so a copy number variant. And so by reading the letters of genetic code, checking for deletions and duplications, we're trying to find out, are there any variants in that gene? And if so, do we think that variant or variant is harmful? So in other words, does that interfere with the normal gene function and potentially cause disease? Or is it just normal genetic variation? We've observed it in the healthy population, and it's nothing that we think is going to be a problem or related to disease. So genetic variation as a whole is very common. It's what makes us unique with our physical characteristics and the way our bodies work, but we know that there are certain variants that can be disease causing. The way that we vet or evaluate a particular genetic change is multifold. So there's all different lines of evidence that we can look at and review to decide what is our opinion of this variant and how do we classify it. We always look to the published literature to see if a particular genetic change has been reported in people who are affected with that condition, and if so, how many, or has it been seen in a family and shown to segregate or associate with disease in multiple people within the same family. We look for functional studies. So researchers will do tests of a particular variant to see, in vitro studies, usually involving cells and cell characteristics, to see if they add in that variant, does the cell or the protein produced by that gene function normally? And we look for that, and that can be strong evidence to support a disease association. There's also computational modeling programs that predict the effect of a particular variant. We have large cohorts of generally healthy people who've had genetic testing to see, do we see that variant in that population? If not, then there's concern that could be disease causing. But if we see it in a relatively high frequency, we think it's more likely benign. And then we also look to internal data if a variant and people tested at our lab before. So I could go on, but there's a lot of different things that we check for each variant. And then all that evidence is compiled and using standard guidelines that we all ascribe to across the clinical lab community, we assign a classification. And so the classification system has a range. Pathogenic is the strongest classification, meaning we know this to be disease associated based on all the evidence. Likely pathogenic is almost there, but maybe lacking a little bit more evidence, but we're still very suspicious. We can get variants of uncertain significance, which just tell us either the evidence is conflicting or we don't yet have enough evidence to feel confident in our classification. Or we have likely benign and benign, which means we have sufficient evidence to think this is just normal variation in the general population and is not disease associated. Most clinical labs will only report variants of uncertain significance, likely pathogenic, and pathogenic variants on the report.
So when you get back a report that says we're not finding anything, there's no Marfan's, no Ehlers-Danlos, we're not really finding anything. But your cardiogeneticist really feels strongly that there is probably some type of connective tissue disease or disorder. Yeah. Then what does that really mean? If it's coming back showing nothing, what would somebody do next? Because that happens to a lot of us. It comes back with nothing.
Yeah, and I think the figure right now is essentially for people who we've ruled out a genetic syndrome, so they don't have something, or at least don't meet clinical criteria for, say, Marfan syndrome, we know that 30% of the time through our current testing methodology, we're finding a causative variant that explains what's going on. So that means 70% of the time we're not. So more often than not, we're getting what you said, either a negative result or just we're not finding that explanation. And I think more than anything, that just tells us we have more work to do in terms of identifying disease-associated genes. So there's a couple things that a patient and physician can do. One is just wait. You know, we always encourage clients or even patients to check back with us in 3 to 5 years, say, or sooner, you know, if there's a particular interest, but to see what have we learned? Have we identified new disease-associated genes? Have our panels gotten much better in terms of sensitivity and what they're picking up? The other thing is, something that can be done more in the immediate time frame is a larger testing panel or potentially whole exome sequencing. So for those who aren't familiar, whole exome sequencing is sequencing of all the coding genes we have that make up all of our cells. And so it's a very large test. There's a lot of filtering that happens there. So because it's such a large test, inevitably we find a lot of variants, but we only really report out or sort by those variants that could likely be in genes, or that could be in genes that are likely associated with the condition that we're testing for. So in genes known to be or suspected to be associated with aortic aneurysm and dissection. So that's one way to potentially get more information by doing a larger test. How much more accurate that's going to be or how much more that picks up really is just dependent on what's going on in that individual and in that family. But the important piece from a clinical standpoint is, you know, even if we don't get an answer genetically from testing that's done, we still look to the family history as a guide. And as I had mentioned before, if there seems to be a strong family history, then you want to manage everyone very conservatively and watch everybody, especially the first degree relatives of the individuals who are affected, until you actually get a genetic explanation that causes the condition and a relative tests negative for that. That's the only time where then we would say for that relative, we could manage more just like the general population and assume general population risk. But if we don't have a definitive explanation for what's going on in the family, then we should take a very conservative approach and manage everyone as such.
So questions I've heard before, and then I'm going to start taking, if anybody has any questions, I'll start taking some questions. If somebody decides to have the genetic testing and you don't, whether you find something related to aortic disease or not, are you going to come back and tell them if they're going to get Parkinson's or if they're at risk for cancer or something like that? I think people have a fear that all of a sudden they're going to get this huge report that's going to tell them everything they never really wanted to know.
Yeah. So, you know, that's something that comes up sometimes with our exome sequencing because we are looking at a bunch of different genes. But from the clinical side, and again, as I mentioned with that filtering, we're essentially only reporting out those variants that are associated with the condition of concern. However, there are some genes where if we find a likely pathogenic or pathogenic variant, there are guidelines that we should report those out or at least give patients the option. So for those particular conditions and those disease-associated genes, the ordering provider should discuss with the patient whether the patient wants that information. And so basically that's an opt-in or an opt-out. Now that's whole exome sequencing. If we're talking about the more frequently ordered testing, which would be like a thoracic aortic aneurysm and dissection panel, where we're looking at a handful of genes, we're only looking at those genes that are associated with aortic aneurysm and dissection. So we are not looking at other genes that might be associated with Alzheimer's disease or Huntington's disease or whatever else it is that the patient might not be interested in, okay? That's where sometimes I think our clinical labs might be, what we do might be confusing to patients compared to maybe advertisements we see on television or hear on the radio about these direct-to-consumer labs, where they may be offering genetic variant information for a variety of conditions or predisposition to certain things like heart disease or conditions that are more common in the general population. So that is not what we are doing. we are very specific in what we're testing for and what we're reporting. And if there would be any of that additional information, like through exome sequencing, we make it clear on our consent and requisition and make sure that the patient is either agreeing to have that information reported if it comes up, or saying, no, I don't want that information shared or reported.
A lot of people that that follow Aortic Hope know that we have shared with them information about participating in the John Ritter Research Program, which research study is not only just to benefit themselves if their genes show something, it's participating in a research study. It's for the betterment of everyone involved as they're seeking out additional mutations. Can you explain a little bit what is the difference really between clinical and research, other than what we talked about already about maybe insurance? I know timeframes are different, expectations should be different as well.
Yeah, so generally speaking, clinical testing is testing for genes that are known to be associated with a disease. That's sort of regarded and understood in the community. These are disease-associated genes, and based on the results of clinical testing, that patient or that patient's family's clinical management may be adjusted accordingly based on those results. So there's a direct correlation. Research testing may be looking in more detail to see if a particular variant is associated with disease, or more likely looking at a large number of genes, or maybe doing something like whole exome sequencing and looking at particular populations, say of people with TAD, to determine, are there new genes, are there candidate genes that we haven't yet described as being associated with this, and can we get enough information from this research testing to suggest, okay, maybe this is what's going on. So that can be, you know, within a family or within a larger context. The methodology is a little different too. So at clinical labs, because we know our results are being used for clinical management, we go through, and any variant that's identified on our initial sequencing run, we go back, or I should say, or deletion duplication testing, we do sort of an initial bulk test or analysis. Any variants that pop up, we then go back using a secondary laboratory method and confirm that that's a true variant. Because sometimes, just based on issues or mistakes or cleanliness of the DNA, so to speak, those initial testing runs can give us sort of a false positive, or say that a variant's there that isn't actually there. So we always go back and confirm that with a secondary method. And research testing, that's often not the case, and they kind of just do that initial run and may report out what they have. They might not report it. So sometimes, depending on the particular study, the patient, when he or she is enrolling, agrees that, okay, none of the results that come up out of this research will get directly reported to me. It's just, again, sort of for the greater good, or maybe the researchers are compiling all of this data to potentially identify a new disease gene. Sometimes we do have patients come to us who did get a result reported to them from a research study. What we always do then is we confirm that. So we do a secondary method at our lab to confirm that it is a true finding. And then after that, their providers can use that information to make decisions about their management moving forward.
Okay. All right. Thank you for that. I'm going to get to any questions that people have, just because I don't want to keep you too late. So John says he had a type A dissection at 43. He has twin brothers who are 12 years younger than him. Should he be tested to help protect them?
Yeah, so, you know, if there's an interest in genetic testing in the family, and if that's something he's willing to do, he would certainly be the best person to first undergo the genetic testing. Based on his results, then we could determine whether testing those brothers would be appropriate. So for example, if he did the testing and we find, say, a likely pathogenic or pathogenic variant, absolutely, testing first-degree relatives like the twin brothers, that would be really helpful for them, because if they test positive, then that means they're at much greater risk and they should be managed much more carefully. But if they test negative, that gives a lot of reassurance. And so their likelihood is not zero, because there's always a chance for these types of things in the general population, but it's essentially closer to general population risk, and they can just follow those management guidelines.
So, and then Kevin says when he dissected, his surgeon told his sisters that they should both be tested. So I thought, and I obviously have it wrong. If for instance, if I was tested, because as you said before, it would make sense that the person who is affected be tested first. If it came back non-conclusive, just nothing, check back in, then would my siblings still need to be tested, or are you really waiting until you figure out what's in me? Then you can go hunt for it in someone else.
Because if you just think of sort of statistically what's most common, if there's a disease-causing variant in a family, it's more likely going to show up in that person who has the clinical presentation or who actually is affected. So the fact that if you had testing and it was negative, but you were affected, the likelihood then if your unaffected sibling had the same testing, the chance that that would be positive is really, really low. It wouldn't really make sense, right? Because we would think, again, the affected person is the most likely to show the genetic variant if one exists.
Right. Okay. Let me just scroll down here. I'm just seeing all these people that are popping in and joining us. Let's see. I know somebody said something was frustrating. I'm not sure if there was something that happened technically or if just the information, and sometimes not knowing can be frustrating. Maybe that's what it was. If anybody has any questions, now would be the time to ask, and we can ask them right here and get them answered. Otherwise, you can always type them, and Jennifer has access, so she can pop onto this maybe by Monday or so and see if you have questions and she can answer them. But in layman's terms, some of the things that I know you are testing for would be Marfan if it was unknown in a family. So if somebody has a dissection and then the doctors take a look and they realize through the general physical testing, I think you might actually potentially have Marfan, you could test for that, for Ehlers-Danlos, for Loeys-Dietz, and for Turner syndrome. Are you testing also for ACTA2?
Yeah, so that is on our panels, and that, as this community might know, that's the gene most commonly associated with heritable forms of thoracic aortic aneurysm and dissection. After that, I'll have to refer here. After that, I believe so there's a gene associated with Loeys-Dietz syndrome, TGFBR2, and actually another one, TGFBR1. So those are the next most common. The gene associated with Marfan syndrome, which is FBN1, that's in there. But after sort of those big three, everything else maybe accounts for 1%, 0.5% of what we know about it. So really the higher sensitivity is doing a panel looking at all of those, unless a patient has a really clear clinical picture. So if somebody meets clinical criteria for Marfan syndrome, you may just want to start with testing for the gene that's associated with Marfan, which is FBN1. But if it's essentially this clinical picture of aortic aneurysm and dissection, but no other physical features or other systemic involvement that would point to a syndrome, then the panel's really the best way to go and just sort of cast the net a little wider for all the associated genes.
Okay. Tammy says, if your doctor hasn't mentioned testing, should you mention it to them?
Absolutely. Yeah. And I think a good doctor who is familiar with genetic testing will sort of educate you about the pros and cons and ultimately leave the decision making to you. Also, if it's a doctor, sometimes heart doctors in particular may not have all the background and training in genetics. So if that doctor doesn't feel comfortable, he or she could refer you to a genetic specialist. So either a geneticist, a genetic doctor, a genetic counselor, somebody who can give you more information. And the idea from the clinical side is before anybody undergoes genetic testing, the patient really should have a full discussion of what the testing is for, how it's done, the possible results, what the implications would be, and make sure that he or she feels really informed enough to either consent to testing or to decide, it's not for me, or it's not for me right now, or I want to look into some other things like life insurance, things like that. But you should absolutely be entitled to having that full discussion of the pros and cons, and then be allowed to make that decision working with a provider who's comfortable with that.
We have Sean. Oh, first let's go to Elaine. Elaine's mother-in-law dissected and passed. Now her husband is diagnosed with aortic aneurysm. Should his siblings and should their kids be tested?
So I think your husband would be the one to have genetic testing first because he's alive and he has that clinical indication. Based on his results, we could then talk about testing other unaffected relatives genetically if we find something of value or something that we think is causative. But if, say, he has genetic testing and his results come back negative, I absolutely think his siblings should be clinically monitored and have at least a baseline evaluation through cardiology to check that piece, because clearly now we have two generations, you know, a mother and a son who've had this issue. So it seems to be likely there is something genetic. It's just a matter of whether our current testing will tease out what that specifically is for this family.
And that sounds very similar to my own situation. My father has abdominal aneurysm. I had a thoracic that I didn't know about till I dissected. His mother and myself both detached retinas. There's degenerative disc disease, there's Crohn's disease sprinkled in there somewhere for good measure. So I had the testing done with GeneDx. My cardiologist, who's a cardiogeneticist, ordered everything. Actually, my insurance did pay for it. I was very lucky. It came back inconclusive with nothing. I'm glad you mentioned when to check back, because I'm rounding my 4 years. So I will be checking back to do it again. And I did have my son baseline echo, baseline eye exam. At the time he was 15. It was the best that they were willing to do. So he will be monitored. And my sister, I believe she had a CAT scan. And so she's got her baselines. And now I guess we just wait. I mean, ideally, you'd love to find something in your DNA or in your genes, because then they know what to look for to know if someone's at risk for it moving forward.
And one of the things I'll mention too is with obtaining new evidence over time, sometimes variant classifications change too. And so that being said, say you get a result that's a variant of uncertain significance, it doesn't always left with an inconclusive. There could be new evidence that we gather over time that either says, oh no, now we actually think this is disease causing, or no, actually this looks like a benign variant. And certain labs like GeneDx will offer a free targeted variant testing policy. So with a lot of our variants of uncertain significance, we're just as motivated as the patient and family to try to get a better classification or a better explanation. And so if there's no family history, then if both parents are living, we can test both parents for that variant to see, was it inherited from a parent? Or sometimes, as can happen, a genetic variant can occur spontaneously or randomly for the first time in the affected individual. And if that's the case, then that's evidence to suggest more strongly that it could be disease causing. Or on the other hand, if there's a strong family history and there's other affected relatives who are living and willing to be tested, then we can offer free targeted testing for that variant in those affected relatives to see if that variant is segregating with disease. And again, that's additional evidence that can potentially help us reclassify that variant. So I really encourage you to, especially if you have had genetic testing and have gotten a variant of uncertain significance and just been told, oh, it's inconclusive, that could change over time too. And you can always check back with the labs to say, hey, is there new evidence? Has this been reclassified? Could you take another look at it? And we're always happy to do that on the lab side.
Now, if you do that, does that mean more blood, or you keep anything stored?
No, essentially it's just more of an analysis.
Oh, that's great.
So we go back. Yeah, so pull all the information from the literature, look at our internal data, rerun computer models, things like that.
Right.
And there are changes. And if that's the case, we issue an updated report with updated recommendations, things like that.
Calling you tomorrow.
All right.
Sean, what Sean was saying when she was frustrated is it's frustrating that her grandfather, mother, and herself, they all have the same disease and all have either dissected or ruptured. And I guess it's killed them, and it's almost killing her, and people don't seem to they're not connecting the dots yet. So I would say, Sean, if you've not been tested, this is a perfect thing for you to do. It's time for you to get tested, and let's see if you can connect the dots, because I don't think anybody thought, and I don't know that it's been proven, but when you have Crohn's disease, it's inflammatory in nature. And none of my doctors thought that between having Crohn's and maybe having an aneurysm that I was worth being monitored. Not realizing that just having that was putting that added extra pressure on my vascular system. So I think as you go year after year, things start to change. Like you said, it creates a different picture.
Yeah. And I think if you're in this position and you haven't had a consultation with somebody with familiarity in genetics, then that's certainly a referral you can request from your doctors too. Even just an information sharing and gathering session with somebody who's familiar with the options, and to decide, is genetic testing right for you or your family, or what's available to you.
Okay. All right. Thank you. I'm so glad we got this to work. I would love to have you come back, please. It's so fascinating. It's so interesting. If you have a link to your company or good information you think everybody out here that follows us that it would help them, one pager or something that I can post on our page and our website so that people can refer back to it, I would really appreciate it. I know they would. And again, just thank you so much for taking the time to really explain it. I'm pretty sure I understood just about almost all of it. It's so fascinating. It's just, you're so passionate about it, which is so great. It's really interesting. So again, if anybody has questions, please just type them in here and Jennifer will check it out and give you an answer.
Yep, I'll follow up in the next couple days and respond to any questions that come up.
Sounds good. Thanks so much, everybody. Sorry for the technical difficulties that we had before, but yeah, thanks again, Jennifer. This was great. We really appreciate it.
No,
Have
take
a
care.
good night. See ya. Bye-bye.